So today's topic would be blood transfusion, the blood components, and the blood substitutes, right, which actually form an integral part of the shock. According to National Blood Transfusion Council of India, the criteria to donate blood, if you want to go and donate blood, what should be your eligibility of a donor? So when you want to donate blood, the first thing to be considered is age. So any patient in the any person, any individual in the age group of 18 to 60 years in general can donate blood if he is a first time donor. You can start at 18 years and you can give up to 60 years if you are a first time donor. But if you are a repeat donor, if you have already given blood before the age of 60 years, you can prolong it up to 65 years. So a person of 62 to 62 or 63 years cannot donate blood for the first time. But if he has already donated his blood in the age group between 18 to 60 years, then he can donate it till the 65 years of age. But if you want to donate it for apheresis is a procedure where you take the patient's blood, extract just the platelets, and then give it back to the patient. So if he is a candidate for apheresis, then it is only 18 to 60 years. 18 to 60 years in general. For a repeat donor, it can be extended till 65 years of age. But if it is for apheresis, it has to be only between 18 to 60 years. Second criteria comes the weight. So the weight of the patient has to be at least 45 kg. And 45 kg, you can take only 350 ml of blood. Blood bags are of two types, 350 ml, 450 ml. If you want platelets, the platelet yield from a 1 unit of blood is very, very minimal. So to increase the platelet yield, you can take blood from 450 ml. From 350 ml, you cannot get much of platelets. So that is why if you want platelets, you need to take 450 ml. But for 450 ml of blood to be donated, the patient has to be at least 55 kg. And for apheresis, the patient has to be 50 kg at least. 45 kg for 350 ml, 50 kg for apheresis, and 55 kg for 450 ml. What if the patient is diabetic? What if the patient is hypertensive and the patient has thyroid disease? Can they donate blood or not? So this is more of a practical class. So if the patient is diabetic and the diabetic status is controlled either by diet or by oral hypoglycemic agents, he can give the blood. But if the patient is put on insulin, now that is a permanent differing criteria. The patient cannot give blood if he is put on insulin, or if the patient has multi-organ dysfunction because of diabetes, or there is a end organ damage. So if the patient has got an end organ damage in the form of CNS disease, CVS disease, or retinopathy, or the patient is on insulin, then he cannot give up blood. Or if the patient is diabetic, his diet and OHA are controlling the diabetes well, and the patient has got not any change of medication in last 28 days. Right? In last 1 month, there has been no change of medication or no change of dosage or the type of the medication, then he can still donate. So if the patient is hypertensive and the systolic BP at the time of donation is between 100 to 140 millimeters of mercury, or the diastolic BP is between 60 to 90 millimeters of mercury, and the patient has not changed his or her medication in the last 28 days, be it the drug or the dosage, then he or she can donate the blood. If the patient has got thyroid diseases, the patient has to be euthyroid and the thyroid disease is benign and it is not a thyrotoxicosis of grave. If the patient was previously hypothyroid or hypothyroid also, he or she can still donate blood, but provided that thyrotoxicosis was not from Graves' disease, because then there are a lot of autoimmune antibodies, right? So these are the three things. So age, weight, and the comorbidities like diabetes, hypertension, and thyroid disease. Obviously, if the patient has got any communicable diseases, any viral diseases, that becomes a total contraindication. Along with that, what frequency can a patient give? So a male can give blood donation every 90 days. but it's a month more for female, and a female can give blood because the erythropoietin contains is slightly lesser, and it is erythropoiesis is also limited by the female hormones like estrogen. That is why every 120 days she can donate blood frequency. When it comes to apheresis, you can donate blood for apheresis for up to 24 times a year, right? Because in apheresis, your blood is taken, platelets are extracted, and blood is given back to you. So you can give blood up to 24 times a year, but there has to be a gap of minimum 48 hours before two donations, right? And maximum of two donations are allowed per week, right? Maximum of two donations per week, and between these two donations, there has to be a gap of at least 48 hours, and you can give for 24 times a year. What about physiological changes? Right? So, if a female is menstruating, you wait till the menstruation is complete and then she can give the blood. If the female is lactating, you wait till the lactation is complete and then she can donate a blood. If the female has got abortion, unfortunately, you wait till 6 months after abortion. And if the female has delivered a healthy baby, after delivery, you wait for 1 year. Right? So 1 year after delivery, 6 months after abortion, and menstruation lactation, till that period she is menstruating or lactating, you try to avoid. So this is the national blood transfusion criteria. This is donor eligibility. Right? Is this clear? Hello.
Yes, sir.
So next would be once the patient comes, sorry, the healthy donor comes and he donates the blood. This blood has to be collected first. The most commonly transfused blood component is a PRBC. Now, when we transfuse PRBC, we do not want any other components apart from PRBCs. But if this PRBC contains WBC, there are two problems with this. One is this WBC is responsible for all the immune reactions because that is the source of antibodies. Now, that is responsible for all the immune reactions. Second, we all know that a virus is an intracellular obligatory parasite. Outside the cell, it cannot survive. So when WBC comes and phagocytoses a virus, this virus will remain within the WBC. Now, if the WBC cannot destroy this virus, now this WBC becomes a carrier for this virus, and that is responsible for transmission of infections. Right? Transfusion transmitted infections. This is responsible. So for that, we need to reduce this WBCs. Now to eliminate the WBCs, and there is no need for WBCs to be transfused in a blood or blood component transfusion. It causes only harm. So to reduce this WBCs, there are two things, two techniques available. One is leukocyte reduction by using leukofilters, right? So before this happens while collecting the blood also. So if there is a donor, you collect this blood from the donor. Before the blood goes into the bag, there is something called as a leukofilter. Right? This happens during collection only. So the blood has to pass through the leukofilter and then it needs to enter into the blood bag. So when it passes through the leukofilter, this leukofilter removes almost 99.9% of the WBCs, right? Which happens during the collection itself. So most of the WBCs are removed. Then to further reduce the WBCs, what we can do is we can wash with saline. Now there are automated machines. Once all the blood processing is all done and PRBCs are taken, these PRBCs, when they are collected, these PRBCs are made to pass through a machine. This has got spiral chambers. Now, this PRBC is mixed with 1 to 2 liters of normal saline and it is made to pass through these spirals of a machine. And somewhere at these junctions in the spirals, there are something called as Y junctions. Now, this spiral comes and it forms a Y junction there and Y junction here, it continues down. Then it forms a Y junction, then it continues down. So, at these Y junctions, the saline escapes. And along with that, it takes all the WBCs also. and only the RBCs trickle down. So this further reduces the amount of the WBCs. This is called as saline washing. When you combine these two, this is called leukocyte reduced saline washed PRBCs. This is what is the meaning of a leukocyte reduced saline washed PRBCs, where leukocyte reduction happens to the blood during collection process and saline wash happens to the collected PRBCs before the transfusion. Now that is done, but most of the centers do not have these leukocyte filters, and that is what is responsible for most of the immunological reactions associated with the blood transfusion. So once you collect it into a bag. Now this bag has a additive that is called as blood bag additive. When they started collecting this blood, so blood inside the body will not clot, but once the blood is taken outside the body, it gets clotted. So to prevent that clotting, they added citrate. Right? So they added citrate. Usually it is in the form of sodium citrate. Now, if you can remember, during massive transfusion, I told you this citrate is responsible for alkalosis because this citrate contains one bag of blood. If it is preserved with citrate, contains 23 milliequivalents of bicarbonate. This bicarbonate produces metabolic acidosis if the patient has problem with renal clearance. And to combat this metabolic alkalosis, the hydrogen potassium pump gets activated. Hydrogen is released outside, which will combat the bicarbonate excess. But to release the hydrogen outside, potassium will go in, and that is the reason for hypokalemia developing in these patients. That is one problem. The second problem is this citrate will combine with free calcium and will produce citrate calcium complexes, which are not soluble in the blood, and that reduces hypocalcemia. So three problems with the citrate is it causes hypocalcemia, it causes metabolic alkalosis, and in order to combat that metabolic alkalosis, body goes into a state of hypokalemia. So that is a problem with that, but that is the most common anticoagulant that is used. But these blood cells in the body get substrate, but outside the body they do not get any substrate, so they wanted to add some substrate and they used dextrose, which was added as a substrate, so that will go inside the cell that and it will result in production of the ATPs. But for at least initial process of these enzymatic reactions to happen, the cell needs some energy, and as an energy source adenine was added. So this adenine is the energy source, citrate acted as an anticoagulant, and the dextrose was a substrate. But when they used this remained only for 21 days. Inside the blood, they used to remain for 120 days, but outside, when they use this ACD, they used to remain for 21 days. So to this, they added phosphate. When they added phosphate, it was called as CPDA, citrate phosphate dextrose adenine, right? So this had a shelf life of 35 days. And this is the most common blood bag additive that is used, CPDA. And I will tell you later that once these RBCs are stored, they undergo certain membrane changes and metabolic changes. These membrane changes, what happens is the capillary diameter is 7 micrometer, and the diameter of the RBC is also 7 micrometer. Now this RBC, if it has to pass through this capillary, it has to squeeze in so that a rounded RBC can assume a shape of dumbbell shape and squeeze through the capillaries, so it can pass through the capillaries without any problem. For this to happen, it requires membrane stabilizers. That is what happens in a hereditary spherocytosis, where the RBC loses these membrane stabilizers and it becomes deformed. The deformability reduces, right? It should get deformed from a circular to dumbbell shape so that it can pass through the capillaries. Now, stored blood has got this deformability. It cannot reduce its deformability. So that is why the osmotic fragility is increased. So to stabilize that membrane, they made this SAG-M, where instead of dextrose, they used glucose. They added mannitol. Mannitol stabilized the membrane, and mannitol reduced the hemolysis, right? So because it stabilized the membrane and it reduced the hemolysis, the shelf life increased to 42 days. So this is the best preservative. Best blood bag additive is SAG-M, which contains saline, adenine, glucose, and mannitol. Mannitol stabilizes the membrane and reduces hemolysis. It has got shelf life of 42 days, but because it is costly and it is not as easily available as CPDA, the most commonly used is CPDA. So these are the three blood bag additives: ACD, which is not used anymore, CPDA, and SAGN. So it is already filled with this additive, and then you take the blood into this bag. So once you take the blood into this bag, to precipitate, the most commonly used process in a blood bank is a centrifugation. So if you want to separate anything, you just subject it to centrifugation. Now this is a blood. So the blood bag that was taken will be centrifuged. So when this blood collected in this bag is centrifuged, all the RBCs will settle down at the bottom. These RBCs settle down at the bottom, and above this there is a layer of WBCs. If the leukofilter was not used, so this forms a layer of the WBCs, and above that comes the plasma. So when you centrifuge it, you get a plasma here. Then there is WBCs, which is called as buffy coat, and then you get RBCs here. Now this is connected to two bags, which are called as satellite bags. So smaller bags that you connect it here, they are called as satellite bags. And now this is placed into a machine where it compresses. So when it compresses this bag, all this plasma which is present here will get escapes into this bag, and all the RBCs will trickle down into this bag. So when all the RBCs trickle down into this bag, these RBCs get packed. That is why it is called as packed red blood cells. Right now, because this Buffy coat is discarded, right? Because WBC has no role and it has got more reactions, more problems than helpful. So it is discarded, and you get all the plasma here. This plasma has neither WBC nor RBC. That is why it is called as, it has got only platelets. That is why it is called as platelet rich plasma, PRBC. Now, this PRBC, when you take it, it can be stored at a temperature of 2 to 8 degrees Celsius. Depending upon the additive it is used, it has a shelf life of 35 or a shelf life of 42 days. And before transfusion, you need to test for ABO incompatibility. Also, you need to test for RH incompatibility. Both have to be tested. And once you issue this back, it has to be started within 30 minutes. If you keep it for more than 1 hour in the outside temperature, it undergoes hemolysis a lot, and it has to be transfused within 30 minutes. And this RBC's transfusion has to be completed within 4 hours. 3 to 4 hours if the patient has got a hypervolemic states, or if he has got cardiac insufficiency, hepatic insufficiency, renal insufficiency, take a little longer, end it till 4 hours. If not, end it within 3 hours. So it is between 3 to 4 hours. It has to be transfused, started transfusion within 30 minutes. Now, what are the problems with a stored RBC? What happens when you store these RBCs? So there are metabolic changes and structural changes. I told you the deformability is reduced so that osmotic fragility is increased, and this makes them susceptible for hemolysis. This is one structural problem. The metabolic problem is that they use ATP. What once the source of ATP gets reduced, they do not have any new source of ATP apart from adenine. Once that also gets exhausted, there is depletion of ATP. This is the first metabolic change. And there is reduction of intracellular 2,3-DGP. And these cells, as they utilize this, the antioxidants, because anything that happens in a body releases oxidative species, which are called as reactive oxygen species. That is combated by presence of antioxidants. Because all the antioxidants get used up, there is reduction in the antioxidants also. And they produce lot of waste that accumulate, and they increase lactate levels and they increase ammonia levels. So there is reduction in ATP, there is reduction in 2,3-DGP, there is reduction in antioxidants, the lactate and ammonia increase. Now what happens because of this? Because ATP reduces, I told you about 6 cell syndrome in the chapter of shock. As ATP reduces, the sodium potassium pump fails. Now, when the sodium potassium pump fails, its job is to put 3 sodium out, 2 potassium in. The potassium cannot go in, and that results in hyperkalemia. That results in increased potassium levels in the stored blood, and when you transfuse it rapidly, especially in massive transfusion, that can lead to hyperkalemia. So that is why the problem metabolic change with the blood transfusion is either hyperkalemia or hypokalemia. Right? I already explained hypokalemia, and this hyperkalemia can happen. And why we always advise to you use young, fresh RBCs is the moment you store it for longer, greater will be the hyperkalemia, greater will be the potassium content. So every day it increases by 1 milli equivalent. As the ATP slowly reduces, the potassium concentration in the bag increases by 1 milli equivalent. So this is the problem. And 2,3-DGP is required to shift the oxygen from the hemoglobin. So at the cellular level, the oxygen has to be dissociated from the hemoglobin. So there is a delivery of oxygen to the tissues. So if 2,3-DGP reduces, then this cannot give proper oxygen. So there is a impaired oxygen delivery at tissue level. As antioxidants reduce, because it is compressed, some of the WBCs can get entered into this PRBC. Similarly, some of the WBCs can also enter into the plasma here. So when these WBCs get entered into this, come with PRBC, this antioxidants reduction will produce the stimulation of reactive oxygen species that will activate the WBCs, and these WBCs produce pro-inflammatory cytokines. And increased lactate and ammonia will also increase the acidotic level. That is what a problem with the stored blood. So it is always better to use a fresh blood. If it is stored for more than 14 days, it has got all these problems. This is a problem with the storage of PRBCs. Now, that is done with PRBC. Now, indication, I hope all of you know about the indication of PRBC. So along with this, you can just add an indication by writing in the exam. Now, the next component that was there was a plasma, which did not have any of the WBCs or PRB. Most of the RBCs and PRBCs were removed from this. So that is why it is called as a platelet-rich plasma. Now, this platelet-rich plasma is made to centrifuge again. So when you centrifuge it, whatever is the cell in that, that gets settled down. So the cells get settled down, and then the plasma remains as a supernatant. Now, these cells are taken into a separate bag. These cells are taken into a separate bag, and that is rich with platelets. That is called as platelet concentrate. That is also called as PC. Now, because all the platelets are lost here, what remains is a platelet poor plasma, PPP. Right? So, platelet-rich plasma is taken, centrifuged, platelets concentrate, and that is called as platelet concentration. What remains is called as a platelet poor plasma. Now, these platelets can be stored at a 22 to 24 degrees Celsius. They have a shelf life of only 5 days, which is 120 hours. Right? From the point of donation, they have a shelf life of only 5 days. And these platelet concentrate, after release from the blood bank, they can be transfused immediately, and they have to be completed within 30 minutes. Usually it takes 5 to 10 minutes to transfuse this. They have to be completed within 30 minutes. But I told you, to get a platelet concentrate, you need a 450 ml pack. 350 ml is not sufficient. Also, with this throw 450 ml, you hardly get a platelet, which when transfused will increase the count to 500 to 1000 only. That is why they take platelets from a multiple ABO, and this also needs ABO compatibility. RH compatibility is not needed, but at least ABO compatibility is needed. Now, they take lot of platelet from different 5 to 6 donors. They take these platelets and they mix this and produce what is called as random donor platelet. So random donor platelets is a mixture of a combination of 5 to 6 donors platelet, which are ABO compatible, and this is transfused. When transfused, it will increase the platelet count anywhere between 5 to 7,000. Even if they mix 5 to 6 donors platelet also, it will increase anywhere between 5 to 7,000. But now there are machines called as apheresis machine. In this apheresis machine, there is a donor. As I told you, the donor criteria is between 18 to 60 years and he has to weigh at least 50 kg for apheresis. Now, his blood is passing through this apheresis machine. This machine will only take platelets and the blood is given back to this patient, right? So you extract these platelets from this patient via the apheresis machine that is from a individual that is called a single donor platelet. And this single donor platelet will increase it by 30 to 60,000. A random donor platelets is from 5 to 6 donors, which increases by 5 to 7,000. But a single donor platelet will increase it by 30 to 60,000. This is by apheresis, for which the criteria is 18 to 60 years, weigh at least 50 kg. Between two donations of apheresis, there has to be a minimum gap of 48 hours and can donate maximum of twice in a week and maximum of 24 donations per year, right? As we discussed previously. When I told you when the blood component strategy was used for transfusion, it was RBC, FFP, and platelet. So there I told you that it is actually 1 is to 1 is to 1, but now it is 6 is to 6 is to 1. The meaning of this is if you take these random donor platelets, they have a yield of only 5 to 7,000. That is why when you use random donor platelets, you need one platelet for every one bag of FFP and an RBC. But when you take a single donor platelet, the count is 30,000, which is almost 6 times greater than that of a random donor platelet. So when you use this single donor platelet or apheresis platelets, you can give one platelet for every 6 RBCs and FFP. That is why it is called as a jumbo bag. Jumbo bag refers to single donor platelet. Right? Is this clear? Hello? Hello?
Yes, sir.
Next component would be what is remained here is a platelet poor plasma. You take this platelet poor plasma and you freeze it to less than 30 degrees Celsius. Now, what you get when you freeze it is nothing but there is no change in the composition. It is just a frozen plasma. That is why it is called as a fresh frozen plasma, FFP. Right? Now, FFP does not contain platelet, RBC, or WBC. What it contains is a coagulation factors. Right? So you can transfuse arm. In platelet also try to add about indications. Right? It is both qualitative and quantitative indications. Along with that, as a part of massive blood transfusion or as a part of blood transfusion to combat diffuse intravascular coagulation. Right? As discussed in shop, you please add those indications also. So this FFP has got coagulation factors. So that is why it is used in all the diseases where there is a deficiency in the coagulation factors. And this is stored at less than 30, minus 30 degrees Celsius. You freeze it. So less than minus 30 degrees Celsius. And it has got a shelf life of up to 1 year. And this FFP, because it has got antibodies there, so you need ABO compatibility. RH compatibility is not needed for FFPs. But even if you do it, it is better. Right? Because what happens when you compress it, one or two RBCs can get escaped into the FFP also. Just like WBC can get escaped into PRBC, one or two RBCs can get escaped into the FFP. So that is why if you do RH compatibility is better theoretically, but practically speaking, it doesn't make much difference. Right? But at least ABO compatibility we have to test it. This is called as fresh frozen plasma. Now, you freeze it to minus 30 degrees Celsius and you store it. When you take this fresh frozen plasma and you thaw, thawing is opposite of freezing. You thaw it to 1 to 6 degrees Celsius and then you centrifuge it again. You centrifuge it, some of the plasma gets separated here and something precipitates down. So it is a precipitate of a cold fresh frozen plasma. That is why this precipitated thing is called as a cryoprecipitate. Right? You get a cryoprecipitate by thawing the fresh frozen plasma to 1 to 6 degree and then centrifuge it. Now what remains here is a cryo poor plasma. Right? What remains is a cryo poor plasma. Now this cryoprecipitate, it has got all the coagulation factors, but as I told previously, it is mainly rich in fibrinogen, fibronectin, factor 8, factor 13, and von Willebrand factor. Right? So cryoprecipitate is a concentrated form of a FFP where it is rich in fibrinogen, fibronectin, factor 8, 13, von Willebrand factor, which are relatively deficient in FFP because they get diluted. That is why the indications for transfusion of cryoprecipitate remain hypofibrinogenemia, factor 8 deficiency, and factor 13 deficiency. So factor 8 is hemophilia and von Willebrand disease, where cryoprecipitate is transfused. Along with that, it is also DIC and transfusion-induced coagulopathy or trauma-induced coagulopathy. So these are the indications. This cryoprecipitate is also stored at minus 30 degrees Celsius. It has got a shelf life of 1 year, and you do not have to test for anything in this cryoprecipitate. I also want you to revise this TEG again, taken in the last class, because it helps to add better indications. That would be better. And what is remaining finally is a cryopoor plasma. Right? Now, this cryopoor plasma, you run it and you take out all the viral infections. And once you take out all the viral infections, you remove antithrombin from this, and factor 11 and antithrombin are removed. And then you pass it through something called as ion exchange chromatography. When you do this through ion exchange chromatography, you get pure factors. So it can be a 3-factor component or a 4-factor component. A 4-factor component contains factor 2, 7, 9, 10, and a 3-factor component contains 2, 9, 10. 7 is not there. So this is called as prothrombin complex concentrate. Now this is how you get a prothrombin complex concentrate from the cryopoor plasma, where you treat it through ion exchange chromatography. Right? So 4-component or 3-component, 2, 7, 9, 10, which are vitamin K dependent. Now this PCC is available in a powder form, lyophilized powder form. You reconstitute it with saline and you give it to the patient. So this PCC can be given in those patients who have vitamin K deficiency, which can be a congenital vitamin K deficiency or it can be an acquired vitamin deficiency. It can also be given in it is a drug of choice in warfarin induced coagulopathy, right? Most of the centers have replaced vitamin K with PCC because vitamin K is needed for production of 2, 7, 9, 10. Here you are directly giving the factors 2, 7, 9, 10. So now most of the centers have replaced this PCC, vitamin K with PCC. So this is how you get different blood components. So now we'll have just a quick summary. So after all the criteria, once the eligible donor is taken, this eligible donor will give the blood, which can be leukoreduced, and the blood is collected into a bag. And this bag has got a blood bag additive. The blood bag additive can be either a citrate phosphate dextrose, adenosine, the ACD is discarded now, or it can be SAG-M. ACD has shelf life of 21, this is 35 days, and this is 42 days. Before taking any further, it is tested for transfusion transmitted infections. Right? We test for 5 infections. One is HIV, HBV, HCV. Along with this, we also test for malaria and syphilis. So if any one of this is positive, you do not test process further. You tell the patient, tell the donor to get tested again for this and get treated. Right. So these are the transmitted infections. Along with that, there can be transmission of parvovirus or hepatitis G1 virus or human T cell leukemia virus 1 and 2 or cytomegalovirus. So these 9 are transfusion transmitted infections, of which we test only for these 5. Testing for these 4 is difficult and time consuming and costly also. Right. So if all of these 5 get negative, we centrifuge it. In centrifuge, we get a plasma, buffy coat, and RBC. We take out this RBC, so that is the first component, which is PRBC. Now you take this plasma, which is called as platelet-rich plasma. You subject it for centrifugation. You get a supernatant plasma, which is poor in platelet, that is called as platelet-poor plasma. Then you have a platelet concentrate. This is second. You take this platelet poor plasma. You centrifuge it again. You get a you freeze it. You get fresh frozen plasma. You take the fresh frozen plasma and you thaw it. You will get a and centrifuge it. You get a cryoprecipitate. This is third and this is fourth. And you take this supernatant cryopore plasma and you subject it to ion exchange chromatography. You get a prothrombin complex concentrate. Right. So this is in summary of all that we have discussed. Now I just want to draw a table so which will summarize the next part. So the first would be a blood component. So the blood component is packed RBC. Then you have a platelet concentrate. Then you have FFP. Then you have cryoprecipitate. Right. Then storage. The PRBC has to be stored at 2 to 8 degrees Celsius. The platelet concentrate at 22 to 24 degrees Celsius. FFP at less than minus 30 degrees Celsius and cryo to less than minus 30 degrees Celsius. And then shelf life. Depending upon the additive used, it can be 35 or 42 days. Platelet 5 days. FFP 1 year. Cryo can be stored up to 1 year. So then compatibility testing. The PRBC has to be tested for both ABO and RH. Platelet ABO is sufficient. FFP, theoretically speaking, ABO plus RH. Practically, ABO is sufficient. Cryo has nothing in it, only the factors. So that is why it does not need any testing. Now, when you issue it, when to start? So you start PRBC within 30 minutes. You start platelet concentration immediately, FFP immediately, and cryoprecipitate immediately. Right? And when to finish? You finish it off within 4 hours. You finish it, all of this within 30 minutes. Right? So the universal donor would be someone who has got no antibodies in him or her. So it is O negative for PRBC. But if it is FFP, it would be AB. It doesn't matter negative or positive. But as I told you, theoretically, there's a risk of one RBC getting escaped into it. So AB negative is better because it does not have any antigen at all. So universal donor for PRBC is O negative. For FFP, it is AB negative theoretically. But clinical speaking, AB negative or AB positive is fine. Right? Is this clear, guys? Hello.
Yes, sir.
So along with this, you please try to revise tag. You also try to add tag in your answer. It was there from one of the chapters of shock class, I think. Next is transfusion reactions. And most of these transfusion reactions we already discussed in massive blood transfusion class, but then again, I'll just repeat it. So when transfusion reaction happens, it can be a immediate transfusion reaction. It can be a delayed transfusion reaction. So immediate, you call it, if it happens within 24 hours, it is called as immediate. If it happens for more than 24 hours, you call it as delayed transfusion reaction. Now, immediate can be hemolytic, it can be non-hemolytic transfusion reaction. Delayed can also be hemolytic. Delayed hemolysis can also happen, or it can be non-hemolytic. So, in non-hemolytic delayed transfusion reaction, it is a graft versus host disease, transfusion transmitted infections, and post-transfusion thrombotic purpura. Right? In the last table, try to add indications also, right? As discussed. It is graft versus host disease, transfusion transmitted infections, post transfusion thrombocytopenic purpura or thrombotic purpura. These are delayed non-hemolytic. There can be delayed hemolysis also. In immediate transfusion, there can be hemolysis. So this hemolysis will lead to the hemolytic transfusion reactions, and there are many non-hemolytic transfusion reactions, right? So we'll take this non-hemolytic transfusion reactions one by one. First is hypothermia. So because these all the blood products are stored at sub body temperatures, all of them have hypothermia. As I told you, in trauma, there is already hypothermia. This hypothermia will lead to coagulopathy. Coagulopathy will lead to blood loss because enzymes can function only at 37 degrees Celsius and at a good pH. This hypothermia, as we discussed, will also lead to acidosis. Acidosis leads to coagulopathy, and that will exacerbate the lethal period of the death. So that is why To prevent this hypothermia, either you thaw them by placing them in a warm fluid, right? Or you have a pre-transfusion warmers are present. You use pre-transfusion warmers, or you can use IV fluid line warmers, right? When it passes through the IV fluid line, they get warm. So you bring them to the human body temperature and you transfuse them. So either you thaw them by placing them in a warm saline, or you use a pre-transfusion warmers and then you use a IV fluid warmers if they cannot be kept in the pre-transfusion warmers, right? So that is about hypothermia. Second is metabolic changes, right? So metabolic changes, as I told you, they contain sodium citrate. Now this sodium citrate contains 23 milliequivalent of 1 unit of blood contains 23 milliequivalent of bicarbonate. This bicarbonate will cause metabolic alkalosis. But to combat this metabolic alkalosis, a cell has something called as a hydrogen potassium pump. So because there is lot of bicarbonate in the blood, hydrogen comes out so as to neutralize the alkalosis. Because it is a cation, for every hydrogen that comes out, the potassium has to go in. And this potassium, all the potassium in the blood will be put inside the cell, and there is a less potassium in the blood that leads to hypokalemia. What I told you, a stored blood will deplete its ATP. When the ATP depletes, the sodium potassium pump fails. When sodium potassium pump fails, its main aim is to put the potassium inside. When it fails, there is a release of potassium, and this blood, when transfused via the central axis or transfused rapidly, as it happens in a massive transfusion, there can be hyperkalemia. Right? So both of them can happen. Also, this citrate binds with free calcium, right? Not albumin bound calcium, the free ionized calcium. It binds with that and it forms a calcium citrate complex, which will lead to hypocalcemia. And this hypocalcemia and hyperkalemia or hypokalemia, all of the three can cause dysrhythmias in the heart. So these are the metabolic problems associated with the blood transfusion. And third, I want to tell about TRALI, transfusion related acute lung injury. This is an immediate complication. This happens within 6 hours. Right? So whenever you transfuse the donor blood, if it is not leukoreduced, or if the patient has got, even if it is leukoreduced, as I told you, some WBCs can still be present in this donor blood. Now this donor blood will have these WBCs, and these WBCs, they'll have anti-HLA antibody, and they will have anti-neutrophilic antibody. Now, this anti-HLA antibody and anti-neutrophilic antibody will come, and these antibodies will stimulate the recipient WBC. They will attack the recipient WBCs. When they attack these recipient WBCs will produce pro-inflammatory cytokines. Now, these pro-inflammatory cytokines will go and preferentially damage lung capillary endothelium. That will lead to the transfusion related acute lung injury, which happens within 6 hours. And because there is a capillary endothelium damage, there is extravasation of the fluid that will lead to pulmonary edema. But this is a non-cardiogenic pulmonary edema. This is a immune pulmonary edema. Right? So TRALI occurs within 6 hours. It is because of the anti-HLA antibodies and anti-neutrophilic antibodies produced from the donor RBC, which will stimulate the recipient RBCs that produces pro-inflammatory cytokines that will damage the lung capillary endothelium, that leads to exudation of the fluid, that leads to pulmonary edema, which is a non-cardiogenic pulmonary edema. Now, if it happens, if the same clinical picture, right? So if you take a PaO2 and FiO2 ratio in these patients, it will be more than 300 mmHg, right? Because there's a respiratory membrane disruption, the amount of the partial pressure in the oxygen in the blood compared to the oxygen that we give from the outside, right? Which is essentially PaO2, FiO2 will become greater. So it becomes more than 300. Along with that, these patients will have bilateral chest infiltrates, right? And it usually happens within 6 hours. If it happens more than 12 hours, that is more likely to be a ARDS and not TRALI. And if the patient, as I told you in trauma, if we initially the concept was to aggressively resuscitate the patient. When they used to resuscitate aggressively the patients, they all of them used to develop ARDS. So if that trolley happens in the setting of ARDS, the prognosis is much worse, and that is called as type 2 trolley. If there is no ARDS previously, that is called as type 1 trolley. Type 1 trolley is a trolley where there is no pre-existing ARDS. Type 2 trolley is where there is pre-existing ARDS. Now, how to manage it? You stop the transfusion and you give symptomatic treatment. Right? You put the patient on bronchodilators. You give antihistamines to the patients. And if it is severe, start the patient on a steroid that will reduce this trolley. How to prevent this? You prevent by eliminating the WBCs. So use of leukoreductors or leukofilters, where you use leukoreduced and saline washed RBCs, will greatly prevent this trolley. Then comes TACO. TACO is transfusion associated circulatory overload. It is simple. If the patient had got a coronary artery disease, if the patient has got a CKD, chronic kidney disease, or if the patient has got chronic liver disease, where already there is hypervolemic status, right? Because of the fluid overload, they cannot take this fluid overload. In such patients, if you transfuse blood, that will lead to obviously heart failure, and heart failure lead to pulmonary edema. Now, that is a cardiogenic pulmonary edema. So you will have all the features, right? The patient will have dyspnea, patient has increased heart rate, patient has increased JVP, patient has tender hepatomegaly, then there is pedal edema. So all the features of heart failure will be present. So it is a simple case of transfusion associated cardiac overload. So TRALI and TACO. Both of them are immediate reactions. This occurs to less than 6 hours. This also occurs within 6 hours. This produces cardiogenic pulmonary edema. This is a non-cardiogenic pulmonary edema. This produces cardiogenic pulmonary edema. On chest X-ray, there will be bilateral chest infiltrates. Here, there will be signs of heart failure. Okay? So, how do you manage TACO? You manage TACO by again stopping the transfusion and giving the diuretics. And if the patient has got into cardiogenic shock, you add a cardiac inotropes. Now, how to prevent TACO? So use smaller volume of blood transfusions in these patients and take a longer time, around 4 hours, to complete the transfusion. Right. So this is TACO. Then the patients can have anaphylactic transfusion reaction, or there can be allergic transfusion reaction. You start the blood, these patients develop hives, the patients have itching, the patients develop eczema. So that is the allergic transfusion reaction because of the release of the histamine. So you temporarily stop it, give antihistamines, and then after a period of time, brief pause, you can restart. It is just an allergic reaction. But if it is an anaphylactic reaction, there's a lot of histamine release. The patients will have angioedema. Histamine causes bronchoconstriction, so these patients have bronchoconstriction. Also, these patients have hypotension. So here you stop it, you give antihistamines, and if does not respond, give steroids. If does not respond, you need to give adrenaline also, and you do not start the transfusion again. So this is anaphylactic transfusion reaction and a allergic transfusion reaction. Right? 7-8 would be transfusion transmitted infections, transfusion associated sepsis. Now, transfusion transmitted reactions can happen either immediately or it can happen delayed. Now, this can be, as I told you, it can be HIV, HBV, can be HCV, it can be syphilis, malaria. Along with that, it can be parvovirus, hepatitis G1, human T cell leukemia virus 1 and 2, and cytomegalovirus. These all can happen. Transfusion associated sepsis is along with that if there is a bacterial contamination of the blood products also. Right? Patient will have fever plus chills or rigors, and even the patient can develop hypertension. Right? You prevent them by properly screening the blood, and you treat them by giving adequate symptomatic treatment and antibiotics. And the next would be hypotensive transfusion reaction. So you start a patient on transfusion and the patient has got giddiness. You check BP, the BP falls to less than 30 mmHg, or I mean, there is a fall of BP of more than 30 mmHg. It was 100 when you started, now it is 60. So that is called as hypotensive transfusion reaction, where there is a fall of more than 30 mmHg of systolic BP. Now, this is usually associated with platelet transfusion, right? And this happens in the patients who take angiotensin converting enzymes. So those patients on ACE inhibitors, these patients, as we all know, AC inhibitors patients have cough. This is because of the release of the bradykinin, right? Oh, along with bradykinin, there are many vasoactive amines. This will cause vasodilation also, increase vascular permeability also, and they will also cause cough. So these patients who are on AC inhibitors, when they transfuse with platelets, because of vasodilation and vascular permeability, the BP can fall to more than 30 mmHg. So that is called as hypotensive transfusion reactions, right? The last of the transfusions reactions will be a febrile non-hemolytic transfusion reaction and a hemolytic transfusion reaction. As I told you, hemolytic transfusion reaction is because of the ABO incompatibility. To transfuse an incompatible blood or either ABO incompatibility or RH incompatibility, there is hemolysis. This will lead to intravascular hemolysis. That hemolysis will lead to disseminated intravascular coagulation and the patient will have coagulopathy. Febrile febrile non-hemolytic transfusion reaction is when the patient does not have any hemolysis, but the patient gets fever. This is because of the antibodies in the donor blood. Now, because of the antibodies in the donor blood that is producing this febrile non-hemolytic transfusion reaction, so it would be maximum in transfusion of FFP, because FFP does not have RBC, it does not have platelet, it does not have WBCs, but what it has is a coagulation proteins and it has lot of antibodies. So it is maximum with FFP, and if the patient, it is maximum in such cases where the where the donor is previously sensitized. Like for example, you take a donor who is of negative blood, you transfuse him with a positive blood. Now this donor gets sensitized and there will be formation of antibodies there. Now, if the patient had got multiple transfusions, with each transfusion, the formation of the antibodies increases. Right? Similarly, in pregnancy also, with each pregnancy, the transfusion of the production of antibody increases. So these donors who have got multiple transfusions or multiple pregnancies will have a pool of antibodies, and if FFP with such patients is such donors is taken, that will lead to the febrile non-hemolytic transfusion reactions. So that is why it is maximum in transfusion of FFP, and if you want to avoid it, try using FFPs from those donors who have not had previous multiple pregnancies or previous multiple transfusions. Right? So this is all about the transfusion, blood transfusion. Along with this, please try to add massive blood transfusion also. Right? It was discussed in a class of shock. You add this massive blood transfusion also. Try to revise it. So is this clear? Hello.
Yes, sir.
The last topic would be from the blood would be a blood substitute. Before this, we'll have a small discussion about autologous transfusion. The problem with the conventional blood transfusion is, one is, no matter whatever precautions you take, there is still a possible reaction of transfusion transmitted infections. Second is, if the patient has got a rare blood group, right? If the patient has got a Rh negative blood group, or even rare, if he has got a Bombay phenotype, then massive transfusion or requiring multiple units in these patients becomes problematic. And the third is, if the patient has got some religious obligations, right? Some people do not want to take blood from other people because of the religious obligations. Then in such patients, this becomes a problem. So then the conventional blood transfusion becomes a problem. So to solve all these problems, there was a concept called as autologous blood transfusion, where if a patient is planned for a procedure, so if the patient is planned for a surgery and during that surgery there is an estimated blood loss that requires blood transfusion, before surgery, you can take blood from this patient, store it, you collect the blood, you store the blood, and after surgery, you transfuse it to him, right? This is called as autologous transfusion, where the patients themselves donate the blood, which is stored, tested, and then it is transfused after the surgery. Now, what are the criteria for this? The most important criteria I forgot to tell for a blood transfusion for a donor criteria was a HB level. So it has to be at least 12.5 gram per deciliter for a conventional blood transfusion. But for a autologous blood transfusion, the HB has to be a minimum of 11 gram per deciliter first. Second, the hematocrit has to be at least 34%, right? So 34% of hematocrit and a HB of 11 gram per deciliter for a autologous transfusion. And the first blood has to be collected 40 days prior to surgery. And the last transfusion can be 3 days 72 hours prior to surgery, right? So the first donation has to be 40 days before surgery, and the last has to be 3 days before surgery, and a maximum of 5 units can be taken, not more than five donations. Right? And between each donation, there has to be a gap of at least 3 to 4 days. So at least 11 gram per deciliter, hematocrit of 34%, first donation 40 days prior, last donation 3 days prior to surgery, maximum of 5 units, and there has to be a gap of 3 to 4 days. But if the patient came to you late, right, he has to undergo this planned procedure, but there is no time of 40 days, then to increase the blood count, you can give a recombinant human erythropoietin, right? So you give this recombinant human erythropoietin injections that will increase the yield also and that will reduce the frequency. You can take blood every second day if a recombinant human erythropoietin is given. But again, the problem with this autologous blood transfusion is this is for a planned procedure. If there is a trauma, if there is a war, if there is a natural disaster, and there's a lot of some thousands to 10 thousands of people need blood, then this cannot happen. So for that, they wanted to create something that is as same as a blood substitute. So as we discussed in a chapter of shock, a blood can be replaced by blood alone. You give crystalloids, you give colloids, that will only help you to maintain the intravascular space. So blood has to be replaced by blood alone. But when massive amount of blood transfusion is to be done to large number of people, the availability becomes a question. So, with all those three factors, as we discussed in the autologous transfusion, along with that, if there is a need for massive availability of the blood products, now that brings us to a concept called as blood substitute, where they wanted to create a substance which is similar to that of the blood substitute, meaning the primary function of this blood substitute should be able to deliver the oxygen. Right? So neither a colloid nor a crystalloid can deliver the oxygen, but an ideal blood substitute should be the one which can deliver oxygen. So they should be able to deliver oxygen. They should have a long shelf life and they should be inert so that they do not produce any immunological reactions. They should not be toxic. Right? They should be able to deliver oxygen. They should have long shelf life. They should be inert. They should not produce any toxic reactions and they should persist in the blood. For this, they mainly took hemoglobin and produced this blood substitute that is called as hemoglobin based blood substitute. And then they designed something which did not contain hemoglobin. They were called as non-hemoglobin based substitutes. Now, currently, the non-hemoglobin based substitute is a perfluorocarbons. Right? So, for this reason, they are also called as artificial blood. Right? A blood substitute is also called as artificial blood. Now, To extract this hemoglobin, there are three ways. First way is when you discard the RBCs, you collect these PRBCs, you discard these packed red blood cells, and from these packed red blood cells, you can take a hemoglobin. So that is first. But the problem is for every 2 units of PRBC, you get only 1 unit of HB. To produce 1 unit of HP, you need 2 units of discarded PRBCs, which is again a problem when a massive transfusion is required to a large number of people. Second is you can take them from bovine blood and a swine blood. You can extract HB from the bovine and swine blood, which is available in abundance, but again, there is a risk of bovine spongiform encephalitis that can be spread. Third is you can culture this E. coli and you can genetically engineer them and produce HB, right? Just like insulin is produced, you can produce HB also. But the problem is 750 liters of culture will produce only 1 unit of HB, which is again a lot of time consuming and it is difficult. So these are the sources for a HB based blood substitute. When they first took this HB based blood substitute, it was a free hemoglobin. So they just extracted this free hemoglobin and they injected into the blood of the patients so that it can deliver the oxygen. But the problem with this free HB is it has osmotic diuresis effect and it will cause renal problems. And this HB, when it undergoes degradation, that will produce toxic substances. And then fourth is this HB is a tetramer, right? So there are the globin has got four attachments, so it is HB is a tetramer. Now this tetramer and the solution that is used to transfuse this HB, they both reduce nitric oxide levels, so that will lead to vasoconstriction. So this was the first generation blood substitute where only free hemoglobin was used. Next, what they did is to try to reduce all these side effects, they produced this second generation hemoglobin. So these were called as hemoglobin oxygen carriers, right? So they are called as hemoglobin oxygen carriers. First, they used a tetramer, but along with this tetramer, they added a diaspirin, which is a aspirin, right? So added diaspirin and they produced this diaspirin cross-linked hemoglobin, which was called as heme assist. So they added a diaspirin, which was called as diaspirin cross-linked hemoglobin, that is a heme assist. But this tetramer was responsible for the reduction in the nitrous oxide. So next they produced polymers. So these polymers, they cross-linked these tetramers and they produced these polymers. So those polymers were called as HbOC201, HbOC 301, right? So HbOC201 is called as HemaPure and 301 is called as oxyglobin. Even if you don't remember these names also it is fine. So it is HbOC201 and HbOC301. And then they wanted to, these polymers also contain some amount of tetramer. So they completely wanted to eliminate all the tetramers. So such that they produce only less than 1% of tetramer were present in them. That was called as polyheme. Right? So this had a shelf life of 3 years and a polyheme had a shelf life of 1 year. So these are second generations. One is diaspirin cross-linked hemoglobin and HbOC201, HbOC301 and a polyheme. But again, the problem of side effects remain. So now they produced third generation. Now third generation hemoglobin based blood substitutes are you take a hemoglobin and you combine it with a phospholipid or a cholesterol so that you form a liposome. You form a liposome which covers this hemoglobin, so that will further reduce the side effects. And or they wanted to take this hemoglobin and enclose it in a artificial RBC. These are all still under trials. So either you make a liposome of a HB phospholipid and a cholesterol, or you take HB and you enclose it in a artificial RBC. So that is about a hemoglobin based. Now the non-hemoglobin based blood substitute, the only thing that is available is a perfluorocarbon. Now this perfluorocarbon exists at a gas form, but if you can alter this chemical composition by fluoridating it, you can make it into a liquid. As we all know, the oxygen in the blood is carried by hemoglobin, but 0.3% of the oxygen is also dissolved in the plasma. So the same concept is taken here. So it dissolves these crystals dissolve the oxygen in them, and their dissolution in PFC is much more than what oxygen is dissolved in the plasma. So that is why this PFC was used as a blood substitute. You get a first generation PFC and a second generation PFC. First generation PFC has to be stored at freezing temperature, and the second generation can be stored at 4 degrees Celsius. This is water insoluble. This is water soluble, right? So water soluble because PFC is usually not soluble in liquid, and plasma contains lot of water. So that is why you need to emulsify it. You need to add a emulsifying agent so that it becomes water soluble. Again, this PFC is still under trial. One more thing that is not actually a artificial blood, but it still can be considered is a when you have umbilical cord, you take this umbilical cord blood, and from this blood you culture this RBCs, that is called as farming, right? You take the umbilical cord blood and you farm it, and you can get a hematopoietic. So these contains hematopoietic stem cells. You add proper enzymes to it and proper growth factors, hematopoietic factors to it, colony stimulating factors to it. You will get a RBCs from there. So that is also one of the method to obtain these RBCs, but that is not actually artificial blood because it is generated from the hematopoietic stem cells only. So it is from the cell itself. So you cannot consider it, but it is still a good alternative. And one umbilical cord can produce up to 20 units of RBCs. Okay. So this is about blood substitutes, which is rarely